So we shall now go on to our first speaker, Dr. Subhash Prasad, who's the director and the founder member and chief consultant of Divya Drishti Eye Care Center, Patna. Again, a very prolific surgeon and quite a very popular figure of Bihar state based at Patna. And he is going to take us through a very learning video. On to you, Dr. Subhash.
Thank you, ma'am. Good evening, everyone. Am I audible, ma'am? And my video, yeah.
Yes, yes.
So I would be presenting a small video on the reverse optic capture of toric IOL. First of all, I am thankful to you for giving me this opportunity, and I have no financial interest on any of my video presentation. We all know that toric lens has actually changed, revolutionized the cataract surgery as far as astigmatism is concerned. So I got a patient of 65 years male who had pseudopecia in other eye, in one eye, with toric IOL implanted, wanted surgery in the other eye. His toric calculation sheet shows that the incision is at 183 degree and at 180 degree, and the location of the IOL is 3 degree as per the calculation sheet. And after marking the axis, I went ahead with the phaco. There is nothing much to describe here because the cataract surgery progressed in a very predictable manner. Using the Centurion machine, I did the nucleotomy with direct chop, and after accomplishing the nucleotomy, I did a good irrigation aspiration. And the problem started at the time of implantation, which I am going to show, and how I managed that. That is the highlight of this video. So I loaded the toric Alcon toric lens in D cartridge, which is supposed to go through 2.2 millimeter incision. There was no problem in loading. While injecting, I had little resistance, and all of a sudden the lens ejected out like a bullet and pierced the posterior capsule. And this lens was about to fall, and the axis of and the rupture area was at the axis of the placement of the IOL. So immediately I pulled the IOL into the bag. Then at this point of time, since the axis of the placement was lying in the area of the posterior capsule rupture, so I had to think about whether I should go ahead with this implantation or explant this lens and implant 3-piece multi-piece IOL in the sulcus with anterior optic capture. But that would have resulted in significant amount of astigmatism, or place the same lens in the sulcus with optic capture. But this is not to produce a lot of complications. So I went ahead with reverse optic capture, which is actually placing the haptic in the bag and putting the optic in the above the anterior capsular margin and capturing it. That is called reverse optic capture. So using two instruments, this iris hooks and the iris spatula, I just gently slided the optic part of the lens out of the bag and tried to bring it over the rim of the anterior capsule, and keeping in mind that I don't disturb the anterior chamber too much, and gently and gradually the lens was slided out of the bag. The optic of the lens was slided out of the bag, keeping the haptic in the bag, and trying to keep the axis of this toric lens in the area of desired axis of placement. And it required a little bit of slight readjustment at I would say about 5 minutes time. And at this point of time, I was pretty sure that there was no vitreous in the anterior chamber, but I would request everyone to put the triamcinolone at this juncture if you have any doubt of having vitreous in the anterior chamber. And having placed the lens, I did the irrigation aspiration of the visco so that nothing is left. But as such, it was not possible to completely remove. But even then, their patient's intraocular pressure was not much higher, and it required just 2 days of the astazolamide tablet. And you can see here that the axis of the placement is almost coinciding with the axis of the desired area. And the post-op, the patient did very well. This is the 2 weeks picture, and you can see it is in the horizontal meridian and just had small residual error. So this maneuver, this timely action of mine did not only prevent the falling of the lens in the vitreous, but actually ensured that the IOL optic is embraced very well in the strong and safe end of the anterior capsular rays, making everyone happy. So thank you very much.
That was a wonderful presentation and very crisply delivered. Cheers to you, Dr. Subhash. Now we shall go on to the discussion. Now I would ask Dr. Malay this question. Yes, now, if the axis of implantation had been in the opposite axis, and then in that condition, would you have placed the IOL in the bag and aligned it with that kind of small PCR? After all, the PCR was peripheral. Because
I think the surgery which Dr. Prasad has done, Dr. Prasad is an accomplished surgeon.
Yeah.
Is such an experienced person who could do a reverse capture with a PC rent. It was very difficult. Had it been in an opposite direction,
sharing the video.
say,
Video is there.
yeah. So
Video is there.
Suppose
Yeah.
if it would have been at 90 degree, if the lens would have at 90 degree,
Yeah.
rotating would have been very traumatic. And if the astigmatism is not very high, I would like to take this lens out and put a maybe sulcus based lens and be with a bit of astigmatism. But even if the astigmatism is too high, then again you see the risk is both ways. If you are not aligning it properly, then actually you are increasing the astigmatism rather than decreasing it. So
Agree.
that you have to be very careful.
No, but if the axis of alignment had been in opposite and a peripheral PCR and there's no vitreous presenting, it's already, the IOL is already in the capsular bag. We could have gently nudged it and placed it.
Yes.
Dr. Mohan, what are your
Yeah.
thoughts?
I think it's a beautiful video. Subhash, beautifully managed.
Yes.
The only message I want to give everybody, because I've got probably one of the largest complications with IOL implantation. You must have seen my videos on IOL antics and acrobatics. But whenever there is a resistance while implantation of the lens, okay, please don't use that lens. Come out of the eye and maybe re-examine the cartridge or change the cartridge or do something different. Don't try to push this lens inside. If there is a resistance, you can have a crack on the lens, either on the optic. We have seen that in several of my videos, or the haptic, or this can happen also. A sudden, release of the lens and rupturing the PC. But once it is good, because I don't believe in this wound assisted this thing if it's anymore. But wound assisted, you have to be a little more careful. Always make sure that the force in which you inject the lens is a little controlled. So I think this is a very good video, but the reverse optic capture is not an easy joke. He did it so easily. He made it so easy. And the reverse optic capture, because these are all optic lenses, and I'm sorry, single piece lenses, wherein there is no angulation between the haptic and the optic, and it's very difficult to do the reverse optic capture.
Actually,
but he did it so well. Yeah.
Actually, you also need a very ideal size Rexis to do a reverse optic capture.
Yes, fortunately, he had a
5.5 to be exact, or a little smaller too. And because if it's a little larger, then it won't even stay the way it stayed on. It is just a freak chance that he got the right size Rexis, because no angulation is a definite challenge. Now, supposing now you have placed it, would you add any extra medication to this, Dr. Manisha? You have to unmute yourself.
Oh, sorry. First of all, thank you very much, ma'am. This was a wonderful video. Only a master could have done this. I was wondering, even when I was watching, this reverse optic capture was very difficult. And like you said, I was wondering what was the size of the Rexis and what was the size of the optic. So basically, even the post-operative, I would not like to call this patient for a long follow-up. I think a frequent follow-up is more important to check in the post-operative time. And I think that the routine medication, why? Because you said no vitreous had presented itself. So maybe we would not expect more reaction in this patient.
But the haptic is in the bag. Haptic
Yes.
is not in the sulcus, so it's not rubbing on the iris.
Yes, but the optic is rubbing on.
There.
Yes.
Optic is there, but if it is a small size pupil, do you think there will be a rubbing of the optic on the iris?
There is a possibility.
Yes, but we are presuming that these materials are inert generally. So we are hoping that it did not. But like I said, I would like a frequent follow-up on these patients rather than calling after a week or so, maybe daily for a few days to see that they don't have increased reaction.
Dr. Malay, supposing the PCR had been a little larger, what would you do? Like, Dr. Subhash was caught in a quandary because the patient had a toric in one eye and the other eye toric he felt compelled to put, and he managed very well. But if you had a little larger PCR, would you still go ahead and place an IOL in the bag?
So I think if the PCR is too big, then
Not too big, a little bigger.
It's
Not
again,
too big, you can't do.
it depends on whether you can actually manage the lens in the bag or not.
Mm.
Now, suppose if the PCR is too big,
Mm.
then we will have to look into a trans-spiral fixation rather than doing anything which is very heroic in the
No,
bag.
Rexis is intact, no,
Why
Malay.
Rexis is
The Rexis
intact?
is
No.
why we can put a multi-piece lens in the sulcus and capture it.
Capture it.
Yeah, regular optic capture you can do.
Yeah.
Yeah, multi-piece lens and do an anti-vitrectomy. Of course, he mentioned that, Subhash mentioned that about the use of tricot, end of making sure that, because sometimes you can see your the vitreous can be there in the anterior chamber. So make sure that you put tricot and identify the vitreous if it's there, and then put the myocol to make sure the pupil is round.
Yes. Very good. We shall now go on. Excellent, Dr. Subhash. Stay on for
Thank you,
your
ma'am. Thank you.
valuable contributions over the other webinar, other videos which are going to come through.